Ulcerative colitis. It is a form of inflammatory bowel disease, the other being Crohn's disease. It is a chronic, relapsing and remitting ulcero-inflammatory condition that affects only the colon and rectum of the GIT tract. This means that there are relapses in which there is new damage to the bowel known as flares with periods of remission in between. The pathogenesis is not well understood, but just like a Crohn's disease, it also has autoimmune component. There is excessive activation of T helper cells. Here, Th2 subset of T helper cells are involved in people who have HLA-DR2 allele. In these people, the T helper cells undergo activation. They lead to inflammatory process which becomes uncontrolled, and these immune cells attack body's own colon and rectum, leading to cell death, ulcers, and all other manifestations. The pathogenesis is not well understood, but just like a Crohn's disease, it also has autoimmune component. There is excessive activation of T helper cells. Here, Th2 subset of T helper cells are involved in people who have HLA-DR2 allele. In these people, the T helper cells undergo activation. They lead to inflammatory process which becomes uncontrolled, and these immune cells attack body's own colon and rectum, leading to cell death, ulcers, and all other manifestations. Unlike Crohn's disease that can involve any part of the GIT tract, in ulcerative colitis only the rectum and colon are involved. The inflammation in most of the cases starts within the rectum, and in this way it grows back. The inflammation spreads in a retrograde manner involving the entire colon. This inflammation is also continuous and not in the form of skip lesions. Moreover, the ulcers that form due to the inflammatory process are only as deep as involving the mucosa and submucosa, and not a transmural inflammation which occurs in Crohn's disease. When these ulcers form, they cause excavation within the lining. So ulcers with normal mucosa in between is present. These raised areas appear as polyps and are therefore known as pseudopolyps, means false polyps. When the inflammation proceeds, it causes loss of postrations in the colon and converts it into a plain tube. This is seen as lead pipe on barium studies. Moreover, the inflammation causes cell death. The cells that line the colon and are responsible for water absorption, since now these cells die and water cannot be absorbed from the feces, and so it results in loss of loose stools or diarrhea. The ulcers that are formed, they rupture or affect the blood vessels, and there is blood added to the diarrhea. The patient presents with a left-sided abdominal pain corresponding to the location of rectum, which is the most commonly affected organ within the abdomen. It is accompanied with a chronic bloody diarrhea. These attacks are precipitated by physical and emotional stress in many cases, and the loss of blood leads to iron deficiency anemia, seen as microcytic microscopic anemia. The patient is mostly a young adult with 20 to 30 years of age. Patient may present with complication as well, like perforation when the ulcers get too deepened, seen as air under diaphragm on X-ray. Along with it, toxic megacolon is also a serious complication in which there is dilatation of the colon. The ulcers that form in ulcerative colitis may be contaminated with the feces that pass through the lumen. This leads to neuromuscular shutdown. The nerves cannot contract the smooth muscles of the GIT tract, leading to loss of peristalsis. Feces cannot be passed down and so are dumped and accumulated in the area proximal to the affected colon, leading to colon dilatation proximally. Adrenal carcinoma can also occur when there is a history of prolonged disease, about 8 to 10 years, and it is much common in ulcerative colitis than in Crohn's disease. In ulcerative colitis, the autoimmune cells and the inflammatory process can affect other parts and systems apart from the gut. For example, liver, where it causes primary sclerosing cholangitis, vertebrae with ankylosing spondylitis, joints causing migratory polyarthritis, skin with pyoderma gangrenosum and erythema nodosum, eyes, where it causes uveitis, episcleritis, and thromboembolic events when blood vessels are involved. The diagnostic investigations can involve non-specific tests like complete blood count and peripheral smear that shows microcytic hypochromic anemia due to the bleeding, or inflammation throughout the body by raised ESR and C-reactive protein. The presence of anti-neutrophilic cytoplasmic antibody is also seen in ulcerative colitis. When we do a plain X-ray abdomen, we either see increase in diameter of the colon, or when there is perforation of the colon, we can see gas under diaphragm. On barium enema, we see the classic lead pipe appearance of the colon due to loss of its frustrations, and colonoscopy can be done when by which we can see inflamed hyperemic colon, and can also take biopsy in long-term cases. This should never be done when the disease is acute. It can lead to perforation. Medical treatment of ulcerative colitis involves use of drugs that decreases the inflammatory process and causes the immunity to be suppressed. In case of an acute attack, we use aminosalicylates, which are anti-inflammatory drugs that they are used in the form of oral tablets, including mesalazine and mesalamine. Steroids are used along with aminosalicylates, either in the form of a rectal ointment when the disease is mild. If the disease is severe and moderate, then oral steroids are used. After acute attack, the patient is put on maintenance therapy, in which the steroids are replaced with immunosuppressants, since steroids have side effects. Along with it, they have no use in chronic disease. Immunosuppressants include 6-mercaptopurine, which is an antimetabolite, and azathioprine, which causes apoptosis of the T cells. And so all these drugs decrease inflammation within the body and reduces the damage that occurs to the colon and rectum. When there is an acute severe attack of ulcerative colitis and the patient has excruciating pain and excessive loss of bloody diarrhea, then it is a medical emergency. We first resuscitate the patient, as he has lost a lot of blood and plasma volume. We either give him IV fluids. If his HB is less than 10, then blood transfusion. Along with it, IV nutritional support. Specific steps involve use of IV steroids, methylprednisolone. If it is confirmed that there is an underlying infection which has precipitated the condition, as we mentioned before, that physical or emotional stress can precipitate the attack. then antibiotics are given, and prophylactic heparin to prevent venous thromboembolism. If 3-4 day use of IV steroid does not improve the patient, then we use infliximab. If medical treatment fails, there are complications or the symptoms are very severe, then we perform total colectomy. We remove the entire colon along with the rectum. After removing the entire colon and rectum, the ileum is anastomosed with the anal canal. This is known as ileoanal anastomosis. Since the anal sphincters are competent, the defecation can easily be controlled. Another option is to perform a permanent ileostomy. The anal canal stump is closed after removing the entire colon and rectum, and the terminal ileum is brought out in the form of stoma. It is stitched to the skin of inferior abdominal wall, and a stoma bag is attached to it, so the ileal contents can easily empty into the stoma bag. The anal canal stump is closed after removing the entire colon and rectum, and the terminal ileum is brought out in the form of stoma. It is stitched to the skin of inferior abdominal wall, and a stoma bag is attached to it, so the ileal contents can easily empty into the stoma bag. This is a barium enema that shows ulcerations in the proximal colon and loss of it in the area of rectum, lead pipe appearance. This is plain X-ray that shows gastric bubble on the left side below the diaphragm, which is normal, and the right side there should never be air. If it is, it means perforation. A scenario related to ulcerative colitis. A 30-year-old female came with history of rectal bleeding mixed with stools. Note that in case of carcinoma of the colon, the blood coats around the stool. She had similar episodes in past, meaning this is a relapsing remitting conditions which did not improve with antibiotics. She passes 4 to 6 stools per day with tenesmus and urgency. She also gives history of joint pains and oral ulcerations. Colonoscopy shows tribal ulcerated mucosa with loss of vascular pattern. Being young adult and having a bloody diarrhea for 2 weeks, which means it's chronic. She had similar episodes, means it is a relapse again. Not improving with antibiotics means it's not pathogenic or gastroenteritis. She also has joint pains, which means she has arthritis, the extra intestinal manifestation of ulcerative colitis. Oral ulcers usually do not occur in ulcerative colitis. It occurs in Crohn's disease. Friable and ulcerated mucosa shows that it is an ulcerative inflammatory condition. This is most probably ulcerative colitis, inflammatory bowel disease.